is right and wrong. So I hope everyone benefits from this. And the YouTube of this will be there, so feel free to share it with people who are not able to attend. We have an amazing group of panelists today who will be joining us, and I will leave that to our moderator, Julie Samantarai from Detroit, Michigan, who is going to moderate, and she will introduce the panelist. Now, again, I'm just so thrilled everyone is joining us. What I will request for everyone to do, in fairness and respect to our presenters, is for people to mute themselves, please, so that we don't have any sidebar conversations and we can really focus on listening to our presenters and the wonderful information that they have to offer us. And then afterwards, we will open it up for question and answers. Having said that, I am now going to turn it over to Julie.
Thank you, Smriti. Good afternoon and namaskar. I'm Dr. Julie Samantrai. It's a privilege and an honor to introduce our eminent panelists for today for this session. I'd like to welcome Dr. Sumita Mahanti, Dr. K.V. Ganapathy, and Dr. Aarti Bhaskaran to this session. And I'd like to ask Dr. Sumita Mahanti to start first. Dr. Mahanti is a professor and head of Department of Anesthesiology, Palliative Care Unit at Acharya Harihara Postgraduate Institute of Cancer. She's a national faculty of Indian Association of Palliative Care, a master trainer of education in palliative and end-of-life care, a master trainer of attitude, ethics, and communication. Dr. Mahanti has been actively involved with Amrit Dhara, a palliative care organization since its inception. She provides countless voluntary hours caring for the needy. On a personal note, she's one of the kindest and gentlest persons I have come across. Dr. Sumita Mahanti, please.
Thank you, Julie, for the kind introduction. And it's really a great pleasure and privilege for me to be a part of this forum. So can I have the slides actually? I think.
Ma'am, you want to share or should we share?
That's what I was asking you. Just I'm trying.
So, okay, yeah, okay. We'll share, don't worry.
Yeah, yeah. So I'll be talking on palliative care. Where are we? So, am I audible?
Yes, you are.
Okay.
Can you see? Is a slide visible?
Is the slide visible to everyone?
Yes, Dr. Ganapathy. I don't know if you want to make it to presentation view or you can leave it here. Either way is fine. Thank you.
This appears to be fine. There is a...
Huh? It's
continue,
okay.
continue.
No, it is visible or not?
Yeah, visible, visible.
Visible, okay.
Yeah. Go ahead, ma'am. Continue. Start.
Sumita, you are muted, I think.
Yeah. No. Huh?
Now we can hear you.
My topic is palliative care. Where are we? So I'm not able to change the slide. Actually, Dr. Ganapathy, you have done the slide.
Yeah. I'm changing. Go ahead, continue.
You are changing? Okay, then.
Yeah, is there second slide?
प्रतीत होता है कि इंद्राणी मुखर्जी जब एक टीनेजर थी तब उनके 2 बच्चे थे.
When, sorry, hello, can I continue?
Yeah, continue.
Yes, Sumita.
Then when globally the palliative care started, these are the three important indicators that shows a good palliative care, like opioid availability, community participation, education, research, and training. And these are the three indicators that is also applicable for palliative care in India. Next. Next. Dr. Gan. Palliative care was born in India with the starting of Santi Abedana Ashram in Mumbai in 1986, which gradually have two other centers at Delhi and Goa. And then after that in 1988, in Gujarat at GCRI Ahmedabad, the pain palliative clinic was started. And then 1990 in Kerala, the Pain Palliative Care Society, they started a volunteer-driven outpatient service and also a home care service. And gradually, the centers were spread over Guwahati, Chennai, Delhi, and Bangalore. At different cities, they have different palliative care centers. And in 1994, the IAPC registered, Indian Association of Palliative Care was registered in Ahmedabad. And the first IAPC journal was published in GCRI with second international conference. And so coming to access to opioids, in NDPS rule in 1985 shows that India's per capita consumption of morphine was 1/13 of 131 countries, whereas global consumption of morphine was increased to 437%. Just imagine. And in that time in Kerala was having the remarkable improvement in morphine consumption. That is because they have their own palliative care policy, and they have a very good collaboration between the community, NGOs, and government. That is why they could, they have every district, they have a palliative care unit. And moderate improvement in Tamil Nadu, Karnataka, and Delhi, and minimal improvement in other states. Next. So coming to community participation, pain and palliative care societies was started with the involvement of community, started in 1993 in Kerala, which becomes a neighborhood network in palliative care. That was the project funded by WHO. And according to the central government, national policy on palliative care was formed in 2006, and National Program for Palliative Care was formed in 2012. Next. Coming to education, research, and training. Initially, there are 10 days and 2, 4, and 6 weeks of courses for palliative care for the doctors and nurses. And there were also 1 year of fellowship in palliative care. But gradually, in 2012, the MD palliative program was started. And it was started in 4 large institutes like in TMH Mumbai, IRCH New Delhi, and Manipal, and also in Kidwai. And gradually now also in 2-3 places they have started MD palliative medicine. And in 2022, DNB courses started in 9 institutes. And the Academy of Palliative Medicine at Manipal in 2022, they are running the courses in continuously for the training for doctors, nurses, physiotherapists, pharmacologists, and psychologists, social workers, and also for the volunteers. Next. So what is, with all these milestones, what is the challenge before us? Now there is a huge gap actually in the public, how in public hospitals there is delay in access because of high volume. In the private sectors, delay in access is due to high cost. And in isolated centers, delay in access is due to limited exposure. So all these things, that is why the all the patients are not able to get palliative care. Next. So considering all this, so here comes the birth of Amrit Dhara, flowing nectar or care and compassion in Odisha, and which brings high quality care and in early palliative care, best supportive care, end of life care, and also bereavement care. It was started in September 2019, and the number of patients till now is over 600. And here you can see the area of service. We have got a uninterrupted supply of morphine, and there is a daycare facility where you used to do, manage pain, nausea, vomiting, breathlessness, and fatigue, and wound dressing. And we are doing regular training program for the nurses and for the volunteers. Next. 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 Dr. Ganpati. नहीं की ये मुझे. I'll the other participant.
It is shared.
Next. Next.
Yeah. I've shared it.
Next. No, you just change the slide, last one.
Ma'am, 1 second. Somehow it is paused. We're just trying to unpause this one. So,
Why it will pause?
1 second.
But
Isko stop.
you are sharing the screen
Arre-
from your side, no?
1
Resume share.
second, ma'am.
1 second. Resume share. Resume share. इधर है तो
1 second. आपने जो हाँ
resume share.
है, just
हाँ,
wait.
ये तो है. Yeah, I'm doing the.
Huh?
Yeah. Is it visible now? Last slide. Sorry.
नहीं your screen sharing is paused. So मैं जो कर रही थी
Resume
वो
share.
हाँ ठीक है.
Now is it okay?
No, it's not
we are
visible.
just not seeing the slides.
1 second हाँ गुट्टे second में हमको stop करके पुन करिया पड़ियो. Just to wait. It's not letting us share.
He's not letting us share. Can one of you try from there?
माने आपण लॉग आउट करके आप बाहर आसंतु मीटिंग रो आउथरे जॉइन करंतु शेयर करंतु.
नहीं आउ जन पाखरे अछि ना शेयर जूली पाखरे भी
You
अछि.
have shared rather. You can stop it. I'll share from my side.
Okay.
Ah,
Last
Yeah.
job.
Let's, for the India slides, we may just want to share it from here. So either Julie or Nitapa, or I, Julie, do you want to share the slides going forward?
I'm trying to get the slides, Smriti.
Let madam continue. No?
Mitapa, you can continue.
Sumita ma'am, are you able to share?
Yeah, ma'am.
सुमित्रा मैम को परमिशन अच्छी तो शेयर पाई.
I think so हवा कथा.
Okay, it's coming.
नहीं पढ़ने से कोई प्रॉब्लम.
See it now.
नहीं मोरो
Now can you see?
Yes.
Yes.
Yeah. This is the last slide.
So
Yeah, this is-
You can put it on
Now-
slideshow mode.
Yeah.
Presenter mode को पढ़ंतु.
Dhara has got an opportunity to make a difference by getting all the patients from all the districts of Orissa And here you can see there is, according to Globocon, 62,000 of new cancer cases every year in Odisha. So the need is huge. Only there are 4 government hospitals like HPGIC and AIMS Bhubaneswar, and other 2-3 capital hospital and 2-3 corporate hospital where palliative care is available. But here the palliative care is only institution based, whereas Amrit Dhara has started could reach the people in the very remote area and can provide the continuity of care. Actually, once the patient goes back from our hospital, there is no continuity of care. There is no system in place so that they can take help once they go back home. So here, Amrit Dhara plays a very huge role, and in serving those patients of remote areas through teleconsultation, video consultation, and you'll be happy to know that recently we have started 2 nodal centers at Sundargarh and one at Balashwar. That is mainly a volunteer-led, community-based palliative care center. So I think this is a huge step forward to bring dignity and quality of life of suffering patients of Orissa. Thank you.
Thank you.
Thank you, Sunitata.
I would love to take a few questions.
Any questions from anyone?
With the interest of time, if we could finish all the presentations and then we will open it up for question and answers at the end. Thank you.
Okay. So our next speaker is Dr. K.V. Ganpati, PhD in psychology with specialization in psycho-oncology. He's very actively involved in oncopsychology, providing counseling services to pediatrics and adult population at the Tata Memorial Hospital in Mumbai. He is a national faculty of Indian Association of Palliative Care and CEO of JASCAP, a non-profit organization dedicated to cancer patients in Mumbai. Dr. Ganpati has published in national and international journals. He is very passionate about the role of mental health in patients and their families. Dr. Ganpati, please. You are muted, Dr. Ganpati.
I go. Can you see my slides?
Yes, we
There is
can.
some of which we are not able to convert this into a slideshow. Okay, so our friend Sujata is trying, and while she is at it, yeah. Is it better now?
Yes.
Yes, we can see it.
Yes.
Just manually move the slides if you need to.
Yeah.
Yeah. All right, so can I go ahead now?
Yes.
All right. So just before we started this, one of the persons in the group mentioned that everybody is going to need palliative care at some time or the other. We don't have to be a part of the cohort of chronic condition, but even normal aging would see us, diminished efficiency, not physically, but cognitively, emotionally, and socially. And all this thing definitely needs palliative care. So on that note, I'm going to talk about why do we need to look at the psychosocial issues of patients with advanced cancer. So in palliative care, we follow something called as total pain, which I'm sure most of you know. But for some who do not know this, total pain, we talk about the fact that a diagnosis of cancer is not what actually defines me. So while the illness is a diagnosis, the experience is suffering. I have a diagnosis of cancer to a particular part of my body or an organ which is getting treated. But while that treatment is on, me, the human being, and me, the person, suffers a lot. And therefore, when we talk about psychological issues or psychosocial care, we are looking at that person and trying to, as much as possible, change that patienthood to a personhood. That is why we need to look at psychosocial care. So having said that, let me move on. So there are a couple of terminologies that we need to be familiar with. Uh, as per this Lancet Commission, it talks about serious health-related suffering. Now, this term SHS is always used in the context of severe illness and a condition that carries a very high risk of mortality and which is directly the offshoot of the disease. The disease eventually will lead to this. Okay, and the way we die also contributes a lot to this. So suffering, on the other hand, is always health related if it is associated with illness or injury of any kind, which compromises hugely physical, psychological, social, and spiritual which comes in the way of.
With 3 ounces.
Okay, is my pace clear to all of you? Am I clear?
Yes.
Yes.
Yeah. Okay. So what we talk about is earlier on when a patient was ill or anybody with a serious health suffering or a condition like that, it was only the biological model that came into play. That means the doctor would look at the physical part of distress and he or she would treat the ailment and would believe that the person has become all right. But when it comes to something as severe as cancer, it is not that way. While the doctors have treated me for my most important symptom, pain, and I'm feeling much better, I still have a lot of unfinished business that haunts me, and that can become a potential source of distress. I could be emotionally getting. I mean, just to talk about my emotions, I could be very angry as to why I'm being, why do I suffer like this, and why doctors are not able to treat me. Or it could be anger on myself that I had planned such a big, huge life, and I want to do so many things, and look what this disease is doing to me. Or it can be guilt because of my lifestyle habit. People have advised me, people told me not to be a part of it, but then I just didn't listen to them. And today, a cancer or any other COPD or something stalks me, and I'm going to feel very guilty. So any emotion that can be a source of pain to you. I'm very popular with my friends, and every evening, every weekends, I party with them. And I'm one of the person who calls the party. The same me, because of the cancer, the treatment has had such far-reaching consequences on my physical self that I don't want to look at myself in the mirror. So there is no question of me inviting my friends to, meet me, nor I want to meet anybody. And I, get into total social withdrawal space. So that can be a social pain that can come. And finally, an existential question, why me? What have I done? In fact, in my pediatric setting, I have every parent's starting the conversation with me, telling that their child is so good and it's so harmless, so intelligent and is so obedient. Why should such a child get, cancer? And also sometimes I get into severe bargaining with God. There's a spiritual distress that I was such a God-fearing man. And I was every morning, I would pray, every evening I would pray, and not a single day will go without my prayer wherever I am. And I've been such an ardent and devoted, person. How can God punish me like this? So you look at the suffering from multi-dimensional area of not just biology, but also psychology, emotions, social, and spiritual. Now, to drive home the point, I have this case which talks about how biopsychosocial factors influences pain. And why we as psychologists or the psycho-oncologists, we feel the need to address this psychosocial pain, because untreated, unaddressed psychosocial pain can have, exacerbating influence on the physical part of it, and it can definitely pain can get worsened. So here is Mr. R, a 34-year-old father of 2 young daughters, diagnosed to have a squamous cell carcinoma of right buccal mucosa. And you can imagine what kind of a pain that person will have. He cannot chew, he cannot eat, he cannot swallow. All basic functions are compromised. Okay. And sometimes this also, one of the treatment is resection of mandible. That means completely you'll have trismus, malorder, etc., which people do not want to come near him, and he's left to suffer all by himself. Now, doctor has given him sufficient pain medication and looks like he's well under control. But do you think he's really under control when you look at his face? Is that what you get a feeling? No. He is irritable. He is sad. He is anxious and is unable to sleep. And all this thing because of the uncertainty when this trajectory of the disease and the treatment will end. Will it end with a positive outcome? If it doesn't end, what will happen to the source of income for my family? What is going to happen to my true school going children or college going children? Who's going to take care of such things? Now, all these factors can ride over the physical pain, which the doctor blissfully believes that is morphine or is a tramadol or is Ultracet has, given answer to all this thing. It might, I'm not saying no, it can, but more than that, it is, this thing. I can see Sudharani Patnaik has raised a hand. Does she want to say anything?
No.
There's a hand raised, ma'am, so you can put your hand down. Yeah, thank you. And then he's worried about his two children. So you look at this person, he's point number 3, point number 4, point number 5. That is the person. Whereas the first 4 points, 34-year-old, diagnosed to have commercial right buccal because of cancer, deep-seated pain, these are all disease. So you have to, one of the reasons we tell the doctors, the purpose of taking them through the psychological intervention, especially in advanced cancer, is to not look at the special features of the disease all the time. Okay, if he's talking about pain, you could probably get into a kind of a discussion with him that you have titrated the doses of morphine, and therefore that morphine should cease. For all you know, it might not be a physical pain. It can only be pain arising out of other 4 sources. Okay, now from here, we look at this. When we talk about psychological issues, we are talking about 3 very important things. Suffering. What is suffering? An aversive, multi-dimensional, dynamic experience of severe distress. Today, in the psycho-oncology, we use this term distress, which is less stigmatizing. And, also the fact that today, National Cancer, Comprehensive Network has identified this distress as a 6th vital. So more importantly, while you look at the oxygen saturation, temperature, pulse, heart rate, etc., you need to be conscious of the fact that this distressing element and try and find out the key attributes of those distressing elements. And this distress is always associated with event that potentially threatens the intactness of the person. So psychological distress absolutely leads to biological disruption. Me, I'm intact. I've been carrying on my life. I've been doing my work, with great aplomb. And today, thanks to this disease, I'm bedbound. I'm only, surrounded by medicines, and I'm only looking at a chart and hoping that I'm going to feel better, but I'm still not feeling better because of the other psychosocial dimension. Then we talk about distress. It's a feeling of worthlessness. Poor work for performance. What I was, my identities, I was an executive of a company. I'm not, Julie read out my CV and she introduced me as such a, embellished person. Everything goes for a toss when I'm absolutely rendered loss of function, loss of autonomy, loss of power, loss of opportunities. Can you imagine what it can do to me? So therefore, there is a chronic sadness and there is lack of interest and involvement in anything. And now, why do we talk about this? Because the cornerstone of palliative care is quality of life. We are looking at, the 3 stages in India, which is, the first is early palliative care. The intent can be still curative, but the doctors feel that this disease might become irreversible at a point in time. So the psychologists are on board because right at the diagnosis, the person is going to feel anxious, the person is going to feel bad, the person is going to feel angry. So unless and until we do not address this, there's a fair possibility that this person will drop out. It can be non-compliance, and especially in head and neck cancer, we have seen when the pain is overriding, they just don't believe in this. To hell with it, I don't want, and they drop out. They are ready to, and they try all maladaptive ways of coping. And therefore, it is as a psychologist, we, along with the medical doctor, we see that how this quality of life can be preserved or at least improved to some extent, that he or she is able to manage their activities of daily life? Somewhat. So quality of life is multidimensional construct. It is an impairment of physical, psychological, and social functioning due to the disease. So now coming to the my slide here, how distress and quality of life are connected. Okay, talk about quality of life, you're talking about physical functioning, emotional functioning, and along with symptom progression. So while the doctors are looking at the symptom, we psychologists are also looking at the psychopathology. What are those pathological factors which can disturb your mind? So on one hand, physical functioning is pain, fatigue, vomiting, insomnia, appetite loss, and constipation. Talk about emotional functioning. We are talking about anxiety, depression, and demoralization, a sense of hopelessness, absolutely. And if it is ignored for a while, then we have had cases of suicide in our setting. So life is not meant to be thrown away that way. And hence, we look at every progression of symptom, what psychological intervention can we do? Can we get into with the patient and the caregiver, right? And that way we try and do the that way we take care of the psychosocial needs of the person. And finally, as I conclude my presentation, the most important thing when we talk about palliative care is the illness trajectory. Okay, right at the time of diagnosis and the treatment, the patient can have certain induced disturbances, like chemo can give you pains. I mean, I don't have to tell you all, you're doctors. Okay, you can have radionecrosis because of radiation. So all these things can make the patient compromise largely on their functioning. So that time, psychologists are on board to help them. Then comes where the disease become irreversible. No therapy is going to work. So in our setting, once the disease metastasizes, despite treatment, we stop giving any anti-cancer therapy because we deliberately, consciously focus on the quality of life. That's what we call as best supportive care. We look at a symptom at a time, and with medicine, we try and reduce that symptom and the impact of the symptom. And correspondingly, that is the time we choose to talk to the patient because his performance status is good, he's oriented, he's cognitively very alert. So this is the time we start breaking the bad news that his disease is irreversible. And we give some time for that person to sink into this information, but we all have our own inbuilt resilience, and so the patient finds a way of coming out of it, and that's when we can talk about advanced care planning. Of course, there are cases where the patient doesn't come out, but we have strong psychological intervention. And finally, at the end of life, when we look at how we can psychologically support the patient and the caregiver. So on that note, I end my presentation, and I think I've adequately spoken to you about why is the need for psychosocial care, what are those psychosocial interventions, how are they screen and assessed, which we will talk about probably in the subsequent meeting that Sujata might organize this group. So there we can have this kind of learnings. So with that, thank you so much once again. Thanks a lot.
Thank you, Dr. Ganpati. We're going to start with Dr. Aarti Bhaskaran. I'd like to invite Dr. Aarti Bhaskaran. Dr. Bhaskaran is board certified in emergency medicine and hospice and palliative medicine. She's a teaching faculty and medical director at Vitas Healthcare, Fort Worth, Texas. She has held many leadership positions in the past and present. She's very passionate about care plans that provides the patients the dignity and autonomy to choose the care. Welcome, Dr. Bhaskaran.
Thank you so much. Namaskar, everyone. I'm going to attempt to share my screen. Let me see.
You can see.
Need to go into slide mode. Give me a second. So I'm going to start about hospice care, right? the reason we're going to talk about hospice care is because of how
Find the
important.
tender ones, because if we break, then people cannot take.
Can you guys hear me?
Yes, we can.
Oh,
Can
perfect.
people
Yeah.
mute
May I please
themselves? If they're not talking?
Yes, please mute when you're not talking. Thank you.
Okay, so the reason we're going to talk about hospice care is because it plays a vital role in the care of our patients, right? Because what's the next step once all the treatment options are done, and where do these patients go, right? So just looking through healthcare spending, previously average lifespan expectancy was 50 to 60 years, but currently everyone's average lifespan expectancy is almost 80 years, right? So in the US, they looked at healthcare spending, and what they found was the people over the age of 55 years actually account for more than 50% of healthcare spending. Why is that important? Because think about the number of years, the financial burden on the patient from 55 all the way to 80 years, the number of bills they accumulate and all this stuff, right? And so they also found that from 2022, the average increase in healthcare spending went up to 4.5 trillion. And that means that's an increase of about $13,500 per person, right? And so that's a lot. So last year in Chicago, they actually published a study which showed that enrolling in hospice can actually save people money. It saves the healthcare money. And so while this talks a lot about, the study spoke a lot about how much money it saves to the US Medicare system, it also spoke a lot about, how we actually utilize hospice. And if you look on the side here, you would see that people are spending an average of only 18 days in hospice, right? We really want them to be on hospice for, 2 months, 3 months, 6 months, but they're not getting referred to us, and they're only being sent to us very late in their disease stages, right? And so looking at the graph below that, 10% of the people come to hospice in the last 2 days of life, 25% in less than 5 days, 50% in 18 days. So there's only a small percentage of people who are actually on hospice care for greater than that, right? So looking at the impact of hospice care, right? If you look at, this was a study which I thought was very interesting, because if you look at the pie diagram at the bottom left corner, you would see that 7% of the patients were the people who were on hospice for more than 3 months. The vast majority, almost 47% of the people, did not actually get any hospice care. 29% of the patients were on hospice for less than 2 weeks, and 17% were anywhere between 2 weeks to 3 months. And if you look at the graphs, and if you look at the first table, people who are not on hospice in the last month of their life, they spent an average of $28,000 on their care, but people who are on hospice spent only $5,000 on their hospice, right? And without hospice, they're 10 times more likely to get admitted into the hospital for the last month of their life. And they're 5 times more likely to be in the ER multiple times in the last month of life. And the goal of hospice is pretty much not to send them back to the hospital, right? And how do we decide if these patients are eligible for hospice or not? So it's a very simple thing, right? And this is something that almost everyone can use. It's like when you look at your family members, or if you look at patients, the one question you ask everyone is, or ask yourself is, would you be surprised if this patient died in the next 12 months? Right? And that's a question we often ask ourselves. And, family members and all of us have this gut feeling, and, physicians have this gut feeling. And so we wanted to put this to test to find out if this could be an accurate assessment on if, the patient is eligible for hospice or not. And so they did a systemic review and meta-analysis where they reviewed several papers, 26 papers. They pooled all the patients in that, and, and they found out if the physicians had asked that questions to themselves. And they found that, amongst all healthcare providers, the physicians were more accurate than nurses at diagnosing patients when they were at the last year of life. And the pooled accuracy is about 75%. So that tells you that if you ask yourself that question, and if you answer yes, then it's more than likely that this person has less than a year to live, right? And if you look across various settings, if you look across oncology, because people with cancer, it's definitely clear the trajectory of their illness. And so when they look at cancer patients and they wanted to check, where the oncologist better at predicting when a person is, how much time they have left or their prognosis, and they found that 75%. So on an average, oncologists, physicians, if you felt that life expectancy was less than 6 months or if they're imminently dying, 75% of the times they were right that yes, this person has a limited lifespan, right? And that limited lifespan can be anything depending on the trajectory of the illness. So I would request that when you have a patient in front of you or your own relatives, if something is not going well, and if you ask yourself this question, and if your gut feeling things says yes, then you might want to consider hospice or at least palliative medicine to begin with. So this is another important study that was done to say that how often do we actually follow patients' wishes, right, when it comes to their own healthcare? What we found is that 7 out of 10 patients felt that they wanted to die at home, but less than 4 out of 10 people just they felt they would, but they didn't think that would be possible. And of all the patients they pooled in the study, only 1 in 10 ever had a discussion about their own wishes pertaining to their healthcare with their providers, right? So what does that look like? It's like when somebody has cancer, it's like sitting down with them and saying, hey, your disease is progressing and you're not doing very well. So if it comes to a point where you can't make decisions for yourself, or if the medicine isn't working, what would you want? Even those simple conversations can mean a lot for the patients, right? But I don't think that, people are taking the time to have those conversations. And when they did have those conversations, what they found was the most important thing for most patients was not to burden their family financially, because healthcare costs are rising and they don't want that their loved ones are left with all these medical bills, right? And the second most important thing to most of these patients was to make sure that their wishes for their own care was being followed. But unfortunately, if we don't ask patients what they want for themselves, we won't be able to follow or even know what they would want, right? And the least important thing for all the patients in the study was to live as long as possible. So I think as physicians, we're taught through med school and all our training that our goal is to cure illnesses and make sure the patients live happily, are comfortable, that we're managing illnesses. But unfortunately, at some point, we all have to realize that medicines only do so much, right? But when do we decide when that point comes, right? Or who decides that point, right? And so we're not taught that through med school or anything. And we're also not taught on how do we manage these patients once we know they are at that point, right? And like Dr. Ganapathy rightly said, there's a lot of emotional and psychological distress that goes with having a terminal illness, right? And this is where hospice comes in, right? Where what does hospice do? It improves the quality of life at end of life. We manage symptoms. We decrease a lot of the prolonged grief and emotional distress that goes along it. We decrease the ER visits, hospitalizations, rehospitalizations of these patients. Because what we have found is that when patients go to the hospital at end of life, they're actively dying or they're not doing very well, they have bad cancer, they have a stroke, whatever reason, the first thing that happens when a patient gets to the hospital is they're put through a battery of tests, and invariably something is found, and then there's an urgency to treat whatever they have found, right? And then the patient may or may not tolerate that, and so that can lead to a lot of discomfort and distress, because the family members would be at this point where they said, hey, treat my loved ones, and the patient is like, what's the point, I'm dying anyway, right? But there's no conversations that's taking place around that, and there's a lot of disconnect in and that given moment, and how do we go forward with this, right? So the patient invariably gives in and said, yeah, do whatever you think is best, right? And we don't want that to go, because despite all of that, at the end of the day, we're not really prolonging a patient's life, even with all the things we're doing, because we're just prolonging the grief that goes along with that. And so, why do I say that? Because when we look, I mean, this is pretty much what CMS tells us we're supposed to look at when we admit patients to hospice. But what I would like you to focus on is just that small square right on top, which says if you think a patient has a life expectancy of 6 months or less, and if the disease runs its natural course, right? So they're not telling you that, hey, if the patient is on treatment and then they're declining, that's when you're supposed to do it. That's not the goal, right? If you think that this person's disease is progressing despite what people are doing, and that if there was no intervention and if the disease were to run its own course, then the patient might have 6 months or less to live. And the 6 months is just an arbitrary time. It's not written in stone, right? It's more than likely that they could have 6 months or less to live. I have patients on hospice service who have been with us for a year and a half, because they're progressing, but there's really no other active intervention that's going to change their trajectory, right? And in this case, two physicians have to agree that the hospice is hospice eligible. And it's usually very simple. It's the physician who's referring the patient to hospice, and me as the provider on hospice would say, yeah, this patient is eligible for hospice. But end of the day, coming on hospice service is not a physician's decision. We can suggest that that's the best course of care, but it has to be the patient and or their family members who decide that they want hospice care. And I do want to stress, the patients do not have to have an order for do not resuscitate to be on hospice. They can be full code. They can want to have all, they might say that if I die, please try to resuscitate me, and that's okay. They can still come on hospice service. I'm going to send these slides so you don't have to pay attention to anything that's written on this. But mainly what I'm looking for is when we look at patients, we're looking at decline, right? We're looking at how are they doing from their health standpoint. We're looking at how are they doing functionally, nutritionally, cognitively. What does that mean functionally? 6 months ago, this patient was able to walk around, cook, do things, but now they're bedbound, right? Or they're using a wheelchair, or for whatever reason, they've declined functionally. They're not able to bathe on their own. They're not able to cook. They're not able to dress on their own. They're needing assistance, right? Those kind of things functionally. For nutritional decline, they might have been eating 3 meals a day, but now they're eating only once a day, right? Or they're losing weight. Cognitively, it's more about they were fully active, alert, engaging in activities, having hobbies, doing work, but now they just sit and watch TV. They're no longer engaging, or they're getting more forgetful. There's some memory changes, those kind of things. And then we look at what is the symptom burden from their illness. How much are they actually utilizing the healthcare system? So when you look at healthcare utilization, it could be the number of times they're going to the hospital, the number of times they visit their PCP or their primary care physicians, and how many times are they actually getting infections, or if they have wounds. We're looking at a lot of different things, and we're looking at disease processes. So the benefits of hospice is really because it's covered 100% here, at least in the US, it's covered 100% for them. So there's no out-of-pocket expenses for the patient. We have a multidisciplinary team. We have physicians, nurses, we have social workers, chaplains, and chaplains are pretty much, they deal with patients of all religious walks, right? They're there just to provide support, and they actually work closely with the patient's priests, or their own pujaris and all of that stuff. And we also work with a lot of Hindu communities, Muslim communities, and we work in conjunction with whoever the patient believes, right? And then we are available 24/7, because we have after hour call visits. We can do telecare visits after hours. There's a physician on call 24/7. The nurse visits the patient once a week. We provide all the supplies that they need. We give them, all the home equipment. It could be a hospital bed, bedside commode. We give them rails, walker, canes. We give them incontinence supplies. We provide them with medications, oxygen, whatever they need, a suction machine. We give them all the equipment they need. And we have nurses who can visit the patient 24/7. So if the patient calls and says, yes, I have a lot of pain, or I'm vomiting, a nurse can go out, see the patient, collaborate with the physician, and take care of the patient then and there. We manage all sorts of complex things for patients if they have a vent, if they're on IV medications, they have IV fluids, they need, they have drains, they need oxygen, they're on dialysis, they need some speech therapy or physiotherapy at home. We do a lot of stuff for these patients at home. And one thing I want to stress is home is wherever the patient calls home. That could be at their actual home. It could be if they're living in a trailer park. It could be they're in a nursing home or in a facility. Wherever home is to the patient, that's where we provide care. And what I stress with my everyone in my team is that we are guests at the patient's house, right? They don't come to us where we work, like patients come into the hospital to where we work. We go to where the patients live. And so we treat everyone with dignity, respect, and we give them all the care that they need, at their bedside. So hospice provides 4 levels of care. The routine home care is the most common, where we provide the care wherever the patient calls home. The nurse visits once a week. We have aides, that means these people will go in and visit the patient 1 to 5 times a week. They will bathe the patient, shower the patient, do a little housekeeping. They may feed the patient. They might even make some small meals for the patient and take care of the patient's immediate needs. Of course, they're there only for an hour or so every day, but they will go and do whatever they can for the patient. Then at some point, if the patient has a crisis mode where they have severe pain or an emotional distress, they've fallen or they've hurt themselves, they're vomiting for whatever reason, we can have a nurse go and sit with the patient to manage their symptoms at home. Medicare requires that we spend a minimum of 8 hours in a 24-hour period providing this care, but that's all a billing thing, right? There are several times that we would provide the care for the patient and family and not even bill for it because we do whatever they need in that given moment, right? And then we have respite care. And so, for example, if we have somebody with a stroke who's bedridden and the patient's family have been taking care of him all the time, and sometimes they need a break. So we can actually have the patient placed in a facility for 5 days, and hospice will pay for that care, right? At the facility, we'll pay the facility to have the patient there while the caregivers get a break. It could be various things. It could be because they're going away for a meeting, there's a marriage in the family. It could be that because the spouse fell down is not well, or for a variety of different reasons. We can do emergency respite. For example, we had a patient whose wife was trying to turn him over and move him, turn him over, and she slipped, she fell, she broke her hip. So we kept him in emergency respite, and we actually paid for that care while the wife went into the hospital to have the surgery done, right? And it was our staff who found her, helped the wife, and called 911, and it was such a beautiful thing. And finally, if we're not able to manage them at home, we have an inpatient unit where we have beds, where we have 12 to 14 beds, and we take the patients over there and we manage them till their symptoms are controlled before we let them go back home. This is something that, so that's just an assessment thing, but that's for the next conversation. And I have my contact information on the slide. So if you want to contact me, if you have any questions, please feel free to do that. What I would like to say is there should be a paradigm shift about how we are viewing hospice and palliative care, right? Because I think the concept that has been for so long is that just because, like, if there's no active treatment for the patient, that means there's nothing more that can be done. And so let's give the patient morphine out and keep them comfortable. And that's actually not what we're doing on hospice and palliative care. We're actually trying to make sure the patients can still continue their medicines, still do the things they love. And I have a patient who wants to go play golf once a week. And he's wheelchair bound, but to him, it's like hitting the golf ball. So, we take him, one of my staff will take him to the golf court. He goes and hits the golf ball for like 10 minutes and he comes back home. It's more about meeting the patients and family where they are and making sure that they get the care that they need.
Thank you, Dr. Bhaskaran. And I'd like to thank our amazing panelists, speakers, for such a wealth of information. we have had an insight into palliative care in India as well as in United States. I see a few questions. The first one is from Dr. Chandana Mishra. I'm sorry, from Chandana Mishra, yes. And the question is, doctors are not with patients for 24 hours. What kind of training your organization gives to the supportive staff and family who stay with the patients for 24 hours? If I may ask Dr. Sumita Mahanti to talk about this in India. And
Yeah, at present, actually in Amritdhara, we don't have a indoor facility. So we have regular OPD where the doctor comes and sees the patient. And wherever in case of need, we are giving home visits where a nurse and a volunteer goes. And sometimes if the doctor is required, doctor also used to go. And otherwise, they are on video call or teleconsultation. They are always with them. And accordingly, they used to advise the things. So, and we used to educate and empower the family members also for just for like for small things like for a wound dressing, for a Riles tube feeding, and we used to educate them in our center and train them. And also our team goes to their home, and they also check with the family members whether they are doing it correctly or not, and so that they can do it at home on a regular basis. So that is how we stay connected with the patient.
Thank you, Dr. Sumita Mahanti. I think Dr. Bhaskaran explained about the USA, how the hospice runs. If you want to say just a few words about this question, and we'll move on to.
Yes, thank you. Yeah, so here when the patient comes admitted to hospice, what we do is we have the nurse visits the patient at home when they first come on, and we explain symptoms, we explain medications, we provide them with that information and upfront, and we give them all the materials that they need. And there's a lot of information to absorb when they first come on hospice. And so we actually have them visit, the nurse would visit the patient a few times the first couple of weeks, like maybe once, twice a week, maybe 3 times a week, depending on the needs of the patient, to make sure that they have all their needs that they have. We also have team managers who oversee the nurses, and what they do is they call the patient's family and check in with them to say, hey, do you have any questions, and can we answer any questions? So if it's related to equipment, then they actually help them out. If it's related to medications, then I get on the phone and I would talk to the patients. I make patient visits at home, so I would go see the patients at home and explain things to them. And it's always useful, and I think after a couple of days after they come and get admitted to us, they're a lot more relaxed, and it's easier for them, and they're able to absorb more information. So we give them little by little, but we build on their care. But I think the most important thing that we found is constantly encouraging the caregivers and telling them you're doing a good job, and even recognizing the effort that they're making, because it's hard work, right? But it's recognizing that we're a team, and by encouraging them, like, call us if you don't know, we're here to support you. And we found that that goes a long way in helping these patients.
Thank you, Dr. Bhaskaran. I'd like to apologize to Chandra Mishra. By mistake, I misspoke and said Dr. Chandra Mishra. She's a nurse in USA. Thank you. We have another question here.
I think Tapti is waiting.
Oh, okay. I'm sorry, I missed that.
That's okay. I'm watching the hands.
Okay. So, Tapti, Dr. Tapti Panda, please.
Yeah, hi. Hello, namaskar, everyone. Thank you very much for this amazing talk, all the panelists in India across, and Aarti. By the way, I just want to say Aarti is my classmate from med school, so proud of her, and so happy to have her here. So this question was open to anyone who could answer. When you get patients who are little challenging, like, they don't want hospice, they don't want palliation, they just give up on everything, and they just continue to watch TV, and they refuse every kind of intervention that you want to do. In your experience, how do you approach this? I mean, I do have family members who are in that situation where, no matter what you say or do, it just is impossible to get them out of the frame of mind. So how do we deal with, especially a family member who is very difficult and who you want to help, actually? So how do you deal with that situation?
I guess this is for anyone.
We couldn't hear her clearly. The voice was breaking. So if she can repeat a question quickly, crisply.
So the question is that when you have a challenging patient who is refusing palliation, how do you manage that? Especially if the patient is known to you or is a family member, how do you approach that?
Okay. As a psychologist, the first thing that I do, if I know the patient or the family member, there is a fair chance that I could be biased. So I don't take that case on. I pass it on to the next counselor, number one. Number two, rather than looking at patient refusing any kind of treatment, right? One has to dig deep into what is that? Does it indicate his loss of interest in living? Is that the first telltale sign that he wants some kind of hastening of the death? Is it something that is slipping into depression? Because we cannot only look at refusing treatment in isolation. Along with that, has he lost interest in eating? Anhedonia, something like I would enjoy music, he has stopped listening to music. I love meeting people, I've stopped meeting people. So you need to take all these factors before coming to a conclusion. And if you're looking at only refusing treatment, it can be a momentary anger or a distress that he's not able to cope, he's not able to adjust, right? And therefore, an impeccable assessment needs to be in place before taking on this symptom, which is superficially looking at us. But deep down, there could be something more. Okay. Having said that, there is a bit of challenge in terms of how the disease progresses. But to answer your question in a way that one can think about is refusing treatment has deep-rooted psychological connotations. One has to look at that. Why is this person not interested in getting all right? Or why is this person not complying with the treatment? But it has to be seen with other factors. For example, I would want to ask him, how does he spend his day? When was the last that he spoke to his friend? So I get some history about him from the family, what kind of a person that he was. If he's an antisocial personality, he has had a clinical profile like that or a psychiatric profile like that, then the intervention will be completely different. But this is coming straight out of normal frustration that you and me will have because things are not going the way we are going. Then the intervention will be different. But my experience will want to advise only one thing, that is to look at this symptom of refusing, or this behavior of refusing treatment cannot be taken only at a superficial level. It must be connected to other aspects.
Julie, I'm going to jump in just for a quick second to address something that came in the chat.
Yes.
Some people have asked whether there will be links. The link will be available. Yes, it is. And Swantana has already put access to the YouTube link in the chat. Otherwise, we'll also send it on forward. And some people have asked about the slides. I will put out the slides in a message on OSANet. And if you're not on that and you would still like the slides, please feel free to contact me and I will send the slides to you individually. The other thing I want to read a question that was put in the chat by Aparajita Mishra. And the question is, this is for Dr. Ganapathy. And then after I read this, I know Chandra Nane has her hand raised, so we'll get to you as soon as we address this question from Jitu Nane, which is, Jitu Nane's question is, I have a question for Dr. Ganapathy about mental health impact. How do you really help someone who is worried about the loss of job and young children? In this case, they are worried about the finance, which cannot be addressed unless there is a way to fundraise for the families. So again, a lot of distress.
Yeah, all right, thanks. Can I go ahead?
Yes.
All right. So the first part of the question is talking about loss of something, and loss of a job is a very important factor, not only from the point of view of bringing finance to the family, also as an identity marker. Because I am doing something, I am supporting my family, and I am earning, is a concrete identity for me as an individual. Okay, so the consequent distress is understandable. That's the first thing. Second, is that person in a position to do something that will make him feel useful, worthy, and bring some money? Okay, so let me quickly give you a case that I handled in my hospital. This was a 40-year-old guy from interior Maharashtra. So he was one morning when I was with the doctor in the ward round, I saw that this person was lying there. Normally, I would see him with his wife and his 7-year-old son. And his breakfast was there on the food cart near him. And I saw that the plate was untouched. I went near him. He was not sleeping. So I said, your breakfast is untouched. You don't want to eat? So he said, no, I don't feel like eating. I said, okay. Do you want me to change this? Do you want some fruits? So he said, no, not really. I'm in no mood to eat. And then I dragged a chair. I told him that, is it okay if I sit with you and talk to you for a while? Okay, so I asked him that, what were you doing before coming to this hospital? He said, I'm a mathematics teacher and I teach mathematics to high school children. So I casually asked him, would you like to teach now? So he said, you're making fun of me. I said in a local language, he said, you're making fun of me. How can I do that? I said, no, I'm not telling you to have a timetable, Monday morning, 9:30 to 12:30, this many people. You say, just casually, as a distraction, do you want to do that? Whatever it was worth, I sent a message near the hospital. There are some shanties. Next morning, there were two boys of 14 years who walked in and they said, okay, we want to learn. This guy started teaching. To cut the story short, there came a time when every morning from 10 to 12, there were 15 students of certain grades. And in the evening, 4 to 5, 20 students of certain grade. And when I met him, he said, thank you so much for processing this to me. I don't even feel my pain. And he came and hugged me. So that was one. Then I said, good. I said, what is it? What else do you want to talk about? He said, so, I know my days are numbered, but I'm only worried who will bring money because my wife is not very educated. So I said, can I ask her if she knows anything? Fortunately, she knew tailoring. So I said, we have an Indian Cancer Society very close, where they run cooperative for the patient's family. I went and told them, they gave her employment at 7,000 rupees per month. Okay, so that was second thing that this man was a little happy. Then I said, now what? So he said, now everything's over, sir. Only my 7-year-old, son, 7th standard son. What do I do? So we got our social worker to contact a funder who promised that he's going to adopt the child till he completes his graduation. Now, the loss, which he thought was a loss, obviously because he could not physically get into an organization work, and this rehabilitation that we did was in a way offsetting the loss. The distress arising out of the loss was not so much when he saw that his wife is now settled in a dignified manner. She'll go to the tailoring, outlet in the Indian Cancer Society, bring 7,000 rupees, and his son's education is going to continue. Was assurance enough for him? So what I'm trying to say is, you cannot directly intervene. If it's a person with, battling severe intense cancer with severe symptom burden, it will not be possible to. So we need to find out how can we bring the families daily functioning back as much as possible. That assurance also can kind of work in people's case. I'm not saying I cannot generalize this, but this has definitely been one of the cases, and like this, few other cases. So loss of job cannot be done anything. But if you're trying to minimize the loss and see that his family is coming back on the mainstream, he will be a little happy. That's my take. I hope I answered the question, Aparajita, madam.
Thank you, Dr.
Yeah,
Ganpati.
thank you so much. Yeah.
Chandra Mishra, she had raised her hand. She had something
thank
to
you.
say.
Thank you, Dr. Ganpati, I guess, but you are under S. Patnaik. But anyway, thank you. What I am
Yes.
mentioning here, why I jumped into and say something, you said that you did this, but if you had a collaborative sorry, I'm so excited, collaborative service with the nurses, nursing assistant, the chapel person, the person who even cleans the room.
Yeah.
If you had
Yeah.
that, you would have been got better information at your side from everybody. I am a nurse in America, and that's what we do. We do not do everything. Doctors do not have to. I mean, they should be. They cannot be there 24/7. But even the interpreter. Even I know that the person who cleans it. Why I am saying, because the person always throws the food, and then he came and said that she's completely vegetarian and she's getting everyday non-veg food. So what I'm saying is that it is not that you have to examine, you have your job, but if you have a collaboration of people, which we do that, because I have worked in hospice, ICU, pediatrics, everywhere. I almost worked 30 years as a nurse. So what I'm saying that you will get better information about the patient and give better care. That is the point I wanted to bring. I mean, when we see the patient, we have to do that all round. Even the interpreter, because the person was Patel, he could not say he was vegetarian. So sometimes the jester, the Jamadar who sweep, he was able to tell us. That's my point. From my point, that's it. Thank you very much.
Ma'am, I have to quickly add, I think I should have presented this case in a much better way. We definitely have a multidisciplinary team. I have a chaplain, I have a social worker, I have a counselor, I have a psychologist. So whoever brings, so this, whatever we said, something was done by a social worker, something was done by a volunteer. So what I brought to you the case was how our department handled this. That's what I want to tell you. And I fully agree.
Even the visitors who are like Jamadar, I said, they
Absolutely.
even get pertinent information. If he did not tell us that the food is thrown every day, we could not have known that he was a vegetarian. Nowhere they were written. So what I'm saying, that every person who comes, even the person who gives the water, they are also important. So you need multidisciplinary, so that the patient, and then I don't even want to go to the Aprajita's question. That's another ball game, because my husband was a cancer patient. We were young and we had 3 kids in the college. So I know what I gone through, but I'm not going there. But all I'm saying is the multidisciplinary. Even the smallest person, for the patient good, it can
absolutely
come.
Yes, I fully agree with you. Thank you. I fully agree. Thank you so much.
We have one more question from Ram Prasad Patnaik. How the corporate hospitals in India handle the hospice care expenses?
Dr. Sumita is there?
Yeah, Dr. Sumita Manti. Dr. Manti, you're muted.
Yes. Yes,
they want to know.
Corporate hospital, actually, they have a collaboration with the pharma company, other things. They don't have morphine. Instead of writing the cheapest drug like morphine, they used to prescribe all the fancy drugs. Those are so very expensive. And even the patch, fentanyl patch, buprenorphine patch, all those are so expensive that way. And the room rent and everything in the corporate hospital, that becomes so costlier. And at the end of life, especially in India, actually, if we'll ask, then everyone will tell we want to die at home. But in India, 70 to 80% are dying in the hospital, and 50% of them are shifted to ICU just before death. And out of them, 76% goes back to home, means left the hospital against medical advice. Once their insurance card is over, money is over in the card, so without getting any continuity of care. So that is, and those who remains back, they are prone for getting that inappropriate intervention, like either they'll be hooked onto a ventilator or they'll be on serial of dialysis, like that, or repeat CPR. And so that is how the cost increases. So
Thank you. Are there any other questions?
This
Please
is
raise your
Dr.
hand.
Ram Prasad Patnaik. I was the questioner, and the extension of the how about the government, role of government care and expenses. The government bears the expenses
yeah,
for
in the
hospice
government
patients.
hospital, like our is a regional cancer center. That's the only regional RCC in Odisha, and also in AIMS Bhubaneswar and Capital Hospital, there is an uninterrupted supply of oral morphine. And even if the patches are sometimes are also available, that is free of cost. So that is how it makes a difference. And for bed strength, bed means months together they are in our hospital. So that's makes a difference.
But as per your information, you told that there was no inpatient care for hospice patients. Is that correct? Is that the correct?
Actually, it's a no. I told for Amrit Dhara at present we don't have a inpatient palliative care unit. We have only regular OPD, daycare center, daycare facility, and regular home care service, and regular training programs are happening. But we don't have a indoor facility. That's why.
Are you planning to have Amrit
Yeah,
Dhara?
very much. Very soon we'll be doing that.
Okay, thank you very much.
Anjiyappa hatatichindi.
Anjiyappa has a question. Anjiyappa, please.
Actually, anyway, I'm from California. I have no questions, nothing. I really enjoying the talk, you know. Recently, of course, I had a patient. I have a friend who was on palliative care. I mean, not palliative, hospice care here, you know. And I used to go there every week, once a day, just to spend my time with the patient anyway. And these hospice care were also home care, and they were doing good care. I just wanted to say that recently, last month, I visited Amrit Dhara Bhubaneswar, and actually, I'm really amazed with so little help. And what can I say? Everybody has the same heart. You have to have the heart to take care of those patients. You know, it's not just the money or something, you know, unless you have really a heart to take care of emotionally, psychologically, you can't help these patients. You know, they know what they are, but we have to give them little help, whatever they need, and whatever in that surroundings, you know, the house, the patients, the outpatients, and then the workers. I'm really, really impressed. That's all I want to say.
Thank you,
Even
Anjiyappa.
even our trained volunteers also used to give respite care to the primary care, so that they can take rest for some time, or they can go for their own health checkup. So that way also we are helping the family members.
There's a message in chat. If we could put Dr. Ganapathy's contact information, I think some people are interested in contacting him directly. Would that be okay, Dr. Ganapathy?
Yes, they can always send me a mail and I will respond to them.
Okay. For now, would you mind just putting your contact information in the chat so they can
I
also access that? They can save that. Thank
Sure,
you.
sure.
Are there any other questions? We have to stop in another 5 minutes or so because there is another session, another seminar at 2:00, and we want to give the OSA office bearers an opportunity to take a breath, and they've been more than so accommodating and just wonderful to work with. Are there any other questions? If so, please raise your hand or put it in the chat. I think
Gayatri Brahma. You are muted, please. He's on mute.
I'm Gayatri Brahma from Bhubaneswar, and I'm connected with Amritara Palliative Care. I felt it's my duty to say I'm quite amazed with the way the training is given and how we are connected practically approaching the dealing with the patients and the doctors, how your words are way of spoken, how you listen to them. It is all taught there by the doctors. It has been so inspiring and so very informative and educative also, that it has been very easy for us to deal with even very complicated or traumatic patients. So we have learned, I feel Amritara Palliative Care, actually it is doing a great job, and I'm really proud to be connected with it. Like looking after the patient, even home visit and video calls and everything, they're looked after very nicely. I have given some information about a patient to them, sent the patient to that place, palliative care, and they were very much satisfied about how the morphine has been given, how the end of life treatment is given to him. Like the family, they were very much satisfied, and they had come and talked about it also in our annual day function. So I think it's a great job, and I'm very happy to be connected with it. Thank you.
Thank you so much for sharing.
I also want to echo that Amritdhara. I got a chance to talk to one person from Amritdhara. I was very impressed. She was on the ball game, whatever. You know that I'm not a very easy person to talk to. I argue, but she was able to answer me. She never know me or anything. I was very happy. So what I mean is that I don't know many organizations in Odisha because I live here, but if at all, they were on the top of the thing. So cheers for them. And we must help whatever we can.
Thank you so much. I'm personally involved in Amritdhara, and I just have to say that the people working there, they just have a heart of gold and very, very passionate, sincere. Thank
Yeah,
you.
just wanted to add also, this January, my daughter and me were fortunate enough to visit Amritdhara and actually meet with the staff along with Dr. Mami Parija. And we are totally, the amazing work that is done there is just very touching. And, with limited sources also, how they do house-to-house care on a weekly basis or twice a week, how they are able to support the families who are in distress psychologically. And, it is not easy. And so, we made the decision to actually support Amritdhara in a small way. So we do have a fundraiser ongoing. If anyone in the audience would like to support, please do come forward and inbox me directly. But I wanted to congratulate Amritdhara for the amazing work that you're doing. And senior living is something that they look forward to taking care of in future, but they don't have too much nursing support, which is the key right now. So in whatever way we can help Amritdhara, because of the kind of work they do and the pioneering pilot kind of palliative care that they are providing the patients around, and they get a lot of referrals. So